So holiday pleasures. So the complaint, okay, 47-year-old male, dizzy, short breath, palpitations, okay. No drug allergies, medications just on lisinopril, hydrochlorothiazide, past medical history of hypertension. What do you guys want to know? What? 12 lead, okay.
Yeah. Where's the fire? Recent surgery, recent trauma.
Recent surgery, recent trauma. Syncope. What? Dehydrated. Vital signs, okay. Altered, okay. Not altered, okay. What else? What other things you want to know?
Output bowel urine.
Output bowel urine. Had been taking medications, okay.
Does he drink or do drugs?
Does he do drugs? Recent medication, okay. Good. Okay. So, reports that his best friend died several weeks ago from a car accident. Okay. This is getting into the holiday season. Okay. Just got through Thanksgiving from that standpoint, getting in towards Christmas. And he did some binge drinking. He's drinking a pint of Espolòn tequila daily. Okay. For several days, but he hasn't had really anything in 24 hours. Okay. Lots of stress at home, no SI, no HI, hasn't passed out, nothing from that standpoint, no diarrhea issues, no traumas. Okay. What? Okay. So think about something like Takotsubo's, okay? Okay. These are his vital signs. Okay. So yes, as a reminder, Jesus is watching you when you're doing your respiratory rates. Jesus is watching. Just like Dr. Shree is watching. Okay. If you're going to lie to me, don't lie. Don't put down 18 and 20. Okay. 14, 12. If you're going to lie to me, lie well. Okay.
Look, it goes in fours. I can only do so much.
Okay. All right. So temps 97, heart rate's 135. Okay. Got the 14. Blood pressure's 136. Sat 96%. Okay. Anything else? Sugar. Okay. Sugar was normal. Okay. 172. Vitals. Okay. Cardiovasculars are regular. Lung size clear. Abdomen slightly enlarged. Okay. Someone asked for the EKG. Okay.
Doesn't that have a adverse reaction?
What?
Doesn't that make your tongue swell and everything?
So lisinopril can cause angioedema
Isn't that normally like immediately after starting, or can that be
anytime. I mean, I've had patients been on lisinopril for 15, 20 years and develop angioedema. Okay. What? TXA is the treatment, is one that, okay. So he's on hydrochlorothiazide, he's been binge drinking, okay. From that standpoint, Tim made mention about dehydration as a potential cause from that. What's the EKG show? What? A flutter or AFib? Okay, so you got some flutters up in V1, okay, some flutterways there, okay. Is it regular? Okay, so it's not regular at all. So what's the three things that can cause irregularities in an EKG? What three cardiac arrhythmias are basically classified for a regular process? AFib, a flutter, okay. MAT, so multifocal atrial tachycardia. Okay, and the third one? So it's a little bit, the kind of sort of the kissing cousin of MAT, the wandering pacemaker. Okay? Wandering pacemaker. Okay? Wandering atrial pacemaker and multifocal atrial tachycardia are kind of sort of the same thing. It just depends on if you're over 100 or under 100. But those are our irregular stuff. All right, so this one, he is in AFib with some flutter stuff going on. Okay, so we have a 47-year-old complaining of dizziness from that standpoint. AFib, has been drinking. Okay, what's his problem? What? Doesn't drink on a regular basis. So just binge drink for a couple days. That's it. No history. He does not drink. No drugs. Doesn't smoke. Works a job. It's really just the aspect of his friends and family and all that stuff. Electrolyte imbalance going on.
We didn't have a history of AFib.
No history of AFib. Yep. Dehydration. What?
Well, guess what?
Anything else? Okay. Potential.
Did it mention anything about the wrong color?
What?
Color, is he jaundice at all?
Not jaundice. Okay. Who's heard of this? Okay. So Holiday heart syndrome. Okay. This is a process. Okay. They call it this because when does it normally happen? During the holidays. And what do we do during the holidays? Drink. And what else? Eat bad foods.
Fight with our loved ones.
Fight with our loved ones. Okay. Unfortunately, we do have more car accidents, more accidents, more problems. Okay. So kind of sort of the process or the overview. Okay. We know it's a cardiac manifestation. AFib is what we see from that standpoint. Okay. Transient takes care of itself. Okay. Usually once you get everything balanced back out again, it goes away. Okay. These patients don't need to be on long-term medications and all that stuff for AFib. We do know that, okay, the binge drinking, it's the ones that they binge drink, they stop drinking. What it does is it puts the body into a little bit of some sympathometic, okay, has an increase in the sympathometic side of the house, which causes the atrial irritability going on, all right, and then calcium problems and all that stuff. What causes? Okay, binge drinking, excessive alcohol, okay, holiday stress from that standpoint, overeating, what do we eat during, okay, everything, okay, but the foods have a lot of salt in it, okay, a lot of love, okay. We don't sleep well, and of course, when you drink alcohol, alcohol interacts with your antidiuretic hormone, ADH, okay, which in turn causes you to not, it causes disinhibition with that, so it further dehydrates you. So they are already fluid volume down, salt problems, stress, and all that stuff. We have electrolyte imbalances going on, okay? They can have hyponatremia from peeing off the salt. They can actually drinking too much alcohol, which in turn causes that to have hyponatremia. Okay? Hypomag, okay, magnesium problems. What's the hypophosphatemia? What's the phosphorus for? Why do we need phosphorus? What? ATP production. Okay, adenosine triphosphate. Okay, do I need to have discussions about Krebs cycle, electron transport chain, mitochondria? Powerhouse of the cell. Okay. So another day is another topics. So how do we treat it? What do we do? What? Tell him to stop. Well, he's already stopped drinking 24 hours ago. You have this guy that's in AFib. What do you do?
Give him more tequila. He was doing better when he was
Yeah. Give him more tequila? Okay.
Mainline that shit.
All right, so give fluids. What else?
If the rate is okay, depending on the rate, treat AFib.
Okay, depending on the rate. Okay. So from the aspect, this is your AFib algorithm. Okay, IV fluids, all that stuff. We did add in, or I did add in magnesium. Had a discussion a couple weeks ago with a couple of my critical care docs, and they like going, anytime that they have AFib and they're giving a medication for AFib, they're given magnesium with it. Okay? So if they give dilts, if they give metoprolol, if they're given digoxin, procainamide, they're automatically already given 2 grams of magnesium. Okay? And the thought is that the patients are hypomag from that standpoint. And there's the magnesium itself does help with the irritability side of the house. So it calms things down.
How often are they seeing hypertension follow this? You're throwing a beta blocker or
There's a little bit, you have to be careful from that standpoint. So if they already have a low blood pressure, low MAP, okay, because from the standpoint of with your dilted metoprolol, what does that do to the heart? Is it a positive, negative inotrope? What's inotropy? Squeeze and contract. So are beta blockers, calcium channel blockers, are they negative or positive inotropes? Negative inotropes, which means that they actually, the squeeze is not as good. Okay, so if you have a low blood pressure with giving them DILT, what's going to happen? Drop the blood pressure because of the squeeze. Okay, and remember, cardiac output is heart rate times stroke volume. Stroke volume is based upon preload after load contractility. It's that inotropy contractility process. Okay, yes, no?
So if I'm putting in a blocker and magnesium, what's connected with calcium channel blocker, am I getting low blood pressure? Am I just putting in pressors? Do I need to consider some calcium on top?
Yes. Yeah. And if you have a problem, okay, and if their blood pressure is low and they're in fib, what's the ultimate therapy? Edison medicine. Okay? Let them ride the white lightning. Okay? Or if you have to push those pressors, bring the blood pressure up, leave it fed. Okay? If he's dehydrated, okay, give them fluids. For this patient with the aspect of the holiday heart, okay, do we need to take care of the AFib? Do we need to give them a beta blocker or a calcium channel blocker?
Probably not. Depends on the rate.
Depends on the rate, okay? Because again, from that standpoint, is you need to tease out what caused the fib. Okay, if this is a 80-year-old that's septic in AFib, okay, do we need to take care of the AFib?
take care of the sepsis.
Got to take care of the sepsis. So that was the discussion, or that was the medical tidbit from this month that I sent out, was you got to take care of what the problem is. Now, if he has a history of AFib and he's at 140 and he has holiday heart on top of it, then yes, calcium channel blocker and all that stuff, knowing that you might drop his pressure a little bit and you're going to have to bump it up with some push those pressors or leave it fed or stuff like that. Okay, yes, no, good. Comments, questions, pitchforks, shovels. Yeah, I mean, if you want to give some mag and just to kind of sort of, the mag's not going to completely get rid of it, the fib, but if you're trying to take care of that, the mag was in conjunction with, if you're giving something, okay, if you're giving a calcium channel blocker or metoprolol, something like that, consider adding the mag and all that stuff with it.
And just be ready with pressures if you need to.
Yes.
Yeah, metoprolol, that's cool. I've been
Just,
doing a lot of AFib lately. I'm excited to try that.
yeah.
You feel like you feel good.
All right, anything else?
Okay, that's unsettling. That's a little creepy. That makes me uncomfortable.
And again, gotta love AI.
I know right now.
I'm loving AI. I had so much fun this past week.
That picture up there came out of his brain.
Right, what? I don't know what it was. I was going to say, what prompt did you put in? But never mind, I don't want to know what prompt. I don't.
Okay.
If that show
Yesterday, I went down the pathway first, but then from there, kind of sort of pull, okay? This is your EKG, okay?
I've seen better.
Okay. And then we'll go backwards. Yesterday, I gave the information, then gave the EKG, so I kind of sort of gave it away first, and then, so I'm backdooring it from there, okay? What do you guys think? What? Does it have a pulse? Okay, shock. Okay, what is this? Okay, VTAC. Yes? SCT with aberrancy. Okay, what else could possibly be?
It could be tox metabolic.
Tox metabolic. Okay. What? Tim still thinks VTAC. Okay, even after our discussions the other day. All right? Too much ketamine going on. Okay.
Wait a minute. Okay.
All right. So your complaint, okay? So this is a 30-year-old female, okay? Weakness, feeling lightheaded, okay? Passed out, okay? Okay. No drugs, medications, lacetabol, hydrochlorothiazide, metformin, history, hypertension, diabetes, and she has AV fistula. All right. Now, again, that's your EKG. This is your patient. EKG, patient. Okay, one more time. EKG and your patient. All right. So what do you want to know? Is she stable? Okay. What's your definition of stable? Mentation, pressure. Okay. Has she missed dialysis? What else?
I'm going to assume, yeah, she's missed out.
What? How much gravy? Do I care about gravy? Okay, so yeah, dialysis, fluids, all that stuff. What else? What else? What else you gotta know? You guys are first on scene. She's over. What are you gonna ask? ABCs. Okay. What? Mentation. Okay. All right. So she came out to visit family over Thanksgiving. Okay. She forgot to call ahead for her dialysis. She's a Monday, Wednesday, Friday. It's Sunday. Okay. So which means what? She needs emergent dialysis. What?
Probably two.
Anything? Anything?
I heard he said she's on dialysis. I'm like,
Okay.
has she missed dialysis? Yes, she has. I already
Yeah. So missed dialysis. Okay. She's been eating leftovers and all that stuff. Okay. A lot of sweet potatoes, a lot of turkey, got some ham going on, green beans. Okay. Got the green beans with bacon. Okay.
Is there another way to do green beans?
All right. Your vitals. Okay. Heart rate 118, blood pressure 176, 105, glucose 254. Okay. She got some crackles. Okay. Pebble thrill. So what are you guys thinking? Bicarb calcium. Why? Tox metabolic. Okay. All right. So what is this EKG? She's going to be a sine wave. So does the history change how you're going to attack your EKG or how your EKG changes things? Okay. So what is this? Is this Y complex tachy? Is it? Hyper K, okay, as a potential. Okay. So what's the characteristics of VTAC? Okay. So VTAC, if they look at it, okay, regular Y complex tachycardia, okay, usually the rate is greater than 120 is the kind of sort of the low threshold, okay. Hers, 118, 115, okay. So does it meet that kind of sort of criteria? So you have the rate, when the rate doesn't meet what it should be, think other things, okay? From there, the QRS complex for Y complex tachycardia is typically between 0.12 and 0.2, okay? So less than a big box. So how do we take care of, okay, Y complex tachycardia? We have someone in VTAC. How do we take care of that? If they're stable or unstable, blood pressure is okay, but they're in Y complex tachycardia. Amio, okay. Amio doesn't work. Lidocaine, okay. What's our dose of amio? 150 over 10. What's our dose of lidocaine?
1 mg per kg.
Huh. Half to 1. Okay. 1 from that standpoint. If that doesn't work or if they're unstable, okay. How much? 200. Okay. Even though the AHA left PSVT and VTAC at 100, okay, we felt in a lot of the systems in the area felt that if we're going to change the AFib to 200, we're just going to go everything. Okay, just to make it easy from there.
Hit your sync button.
Yep. Yes. Make sure that you hit your sync button.
If you don't, this will all get so much simpler for a little bit.
All right.
Later on, it's going to get harder.
So going back, okay, what's this patient's QRS complex?
2 box.
Okay. Well, it depends on where you look at. Okay. I just kind of sort of did down the middle side. So if we do kind of sort of the middle, is it more than one box, one big box, which means that it's greater than 0.2. Okay. So this is, okay, what AMALMA 2 refers to as regular, really wide complex tachycardia. Okay, so anything greater than one big box is regular, real wide complex tachycardia, which is that, by definition, ventricular tachycardia that we need to treat and take care of as a VTAC process. Okay? No, what do we have to think of when we see regular, really wide complex? What's causing it? Okay. For this, if I gave you this EKG, what would you think right off the bat? Hyper K because PT waves. Okay, he's not happy sitting on top of the mountain. Okay. Yes, I typed in unhappy person sitting on mountain. That's what I got. Again, gotta love Google, Gemini. All right. So really, why complex tachycardia? Okay. Kind of sort of when we think about this, greater than 0.2, the things I want you to think about is tox metabolic. Okay. What's the cause from that standpoint? If it's really greater than 0.2. Okay. Hyper K is a sodium channel blocker by itself. Okay. Hyper K will block sodium channels. And then how does amio, lidocaine, procainamide, how do they all work? Sodium channel blockers, okay. So lidocaine is what type, when we go down to our classes, a class 1 is, a class 1 antiarrhythmic is, class 2 antiarrhythmic is, class 3 is, class 4, what electrolytes, what ions are we stopping? Class 1 is sodium channel. Class 2 is beta blockers. Class 3 is potassium channel. Class 4, calcium. Okay, good. All right. We got one. Woohoo! All right. So all of those amio, procainamide, and lidocaine, they all have sodium channel blockade. So they're all class 1 antiarrhythmics. Hyper K is already, okay, so you have already poisoned the sodium channel. So if I give amio, lidocaine, and procainamide to a hyper K patient, what happens to them? You get him. Okay? So you'll go from this nice Y complex tachycardia to PA systole. Okay? So avoid, okay? And again, this is what we see during the holiday seasons. Okay? patients that miss dialysis from that standpoint, if they give you an EKG, okay, stop and look at it. Think, does this meet the pattern? Okay, if it doesn't meet the pattern, the history's weird, stop and think. Okay, this is where the critical analysis comes into play. So potassium, okay, Matu talks about potassium is like syphilis. It's the great imitator. It can do a lot. It can show up as a whole bunch of different places. Okay, so we see the PT waves. We may have the Y complex QRS with the slow VTAC, so a rate of 100, 105, and they look VTAC-ish. Okay, that just doesn't meet the pattern. Right? Asystole, sine waves, AFib with SVR, bizarre. If it looks bizarre, think hyper K. This EKG looks weird. Okay, and how do we treat hyper K? What? Bicarb, calcium, what else? High dose albuterol. Okay? So algorithm-wise, okay, so if you have PT waves, QRS widening from that standpoint, calcium first. We're always taught that calcium is the membrane stabilizer. That's not completely true. It's actually more on the insides of changing ions, the channels. Okay? But yes, it theories, it protects the membrane so you don't get the electrical potential going on, which and then causes the excitation, which causes the action potential, which causes the firing and death. That's what calcium does. And then albuterol and sodium bicarb are ion shifters. They push potassium out of the system back into the cells. That's what their focus is, to get rid of or to lower the potassium. 10 to 20 milligrams of albuterol lowers a half to a point. Bicarb, you give enough to shorten the QRS complex down. And we think, again, it's the sodium. It's not so much the bicarb. We're thinking that it's the sodium. So if you actually give 3% sodium, okay, 100 mLs of that, it's a huge sodium load, and it affects the sodium channels. Okay. That's what the theory behind all that is. Okay. And for this one, I typed in, give me draw the best picture that you can for our EMS ambulance. And it gave me some mushrooms and an ambulance in the middle of the field.
Why is there an ambulance in the Feywild?
What?
Why is there an ambulance in the Feywild?
I don't know. Yeah. So they got this picture of the castle in the background with mushrooms and all that stuff. So, all right. So again, plug ECG Weekly. Get it if you want it. Again, it's cheap yearly. I'm on the 2. Pre-hospital physician YouTube channel that I've created, again, for educational pieces on there at Pre-hospital physician, just from that standpoint. Slowly, it's just education, go from there. So, questions, comments?